Okay, let's get started. So, good day, ladies and gentlemen. This is Sam here, and I'm the sales manager of Middle East from Improved Medical. So, can everyone hear me now? Can everyone hear me now? Okay, everyone can hear me. Test. Good. Okay, let's just get started. So, just welcome to today's training section for our new product overview. So first of all, on behalf of Improved Medical, I would like to thank you very much for your time to attend this meeting. So today I'll be introducing some new products that's highly related to our diet, and this would take about 30 minutes, okay? And you will have this presentation, and our sales representatives will follow you up for all the questions about this training. Okay, let's just get started, and now I will switch the screen to our slides. Okay, so as you can see, today we will go through 3 parts together to understand more about what we're working on. Now let's jump to the first part, which is the company overview. You might be curious about Diagnostic, who is actually a subsidiary of Improved Medical. We've been working together since 2014. So, Diagnostic is a high-tech enterprise that utilizes fishes, as you can see, fishes as a specimen to detect various diseases of the digestive system. This company was founded in 2015, so we have 17 years experience on fishes specimen processing and various detection by molecular biology. Before going to detection, I would like to talk about fishes, which is a very difficult and special specimen. Unlike blood and urine, fishes consists of a lot of components with a lot of solid materials. We could say that 99% of fishes specimen do not contribute to or even do harm to the following analysis. Therefore, we spent years to develop our signature and patented specimen processing technology. So as you can see on this slide, fishes specimen will be injected in the container, followed by mixing and filtration processing in the same container. In the end, we turn the fishes specimen to an applied solution with that 1% useful components for a lot of tests like microscope, colloidal cards, and molecular tests that I will introduce in this training. Okay? The specimen processing we just saw must be done by the automatic instruments. On this page, you could see 3 different automatic fishes analysis systems for all scales of specimen requirements. After processing the samples, microscope and some immunological tests like FOB, HP could be done automatically by these systems. Okay? Apart from the analysis system, we also have 2 sample homogenization processes that transforms specimens to applied solution only for the tests after. So they are easy to use, and they only do one job, which is processing fishes specimen for future detections. Right. So this is the end of the first part, introducing what Diagnostic has been working on. And now with applied solution from the feces specimens, what kind of tests we could do? Mainly speaking, there are two prevalent diseases that's generally related to feces specimen and our digestive system. So in the second part, let's have a look at the diagnostic kit for CRC. So here, CRC means colorectal cancer, which is one of the most common cancers in the world. So the pie chart shows that the morbidity ranks third after breast cancer and lung cancer. We are on the third. And mortality on the right ranks second after lung cancer. Okay? And the morbidity is increasing year by year. So here, what's worse? WHO predicts that by 2030, the morbidity and mortality of colorectal cancer could increase by almost 80%. As you can see the chart here, this is a global health issue, especially for in European countries, Russia, and American countries. Okay. So cancer is a very severe disease that's causing a lot of pain with the patients and their families. But it is not a disease that could be developed in one day, like influenza. No, it actually grows gradually from precancerous lesions. Then, with 4 stages, it starts to go deeper in human body if we do not know they're there. So on this chart, you can see that the earlier the stage is, the harder to detect the cancer. So low detection rate, less than 10%, moderate detection rate at precancerous lesions like here, and in stage 1, stage 2, 3, 4, it has a relatively high detection rate at 70% to 100%. So we are looking at the golden diagnostic stage, which is 30 to 60% detection rate. We want to identify cancer in early stages to cure it, as the 5-year survival rate could be as high as 90% in early stage. But however, if it is already in late stage, when we find it, then it's very difficult to cure it with a 5-year survival rate at less than 10% only. So it's really hard in late stage, as we can see. When we talk about identifying cancers, generally we call it cancer screening, right? Cancer screening. But according to US CDC, currently only 4 types of cancers can be effectively screened, as shown on the table. Class A cancers, including colorectal cancer and cervical cancer, have confirmed to be effective and recommended for screening. But some cancers like pancreatic cancer and prostate cancer are not recommended to screen because it is not beneficial and it is harmful to the body, right? Now, as we know that colorectal cancer is suitable for screening, so what kind of population should be prescribed for screening? Considering different risk factors as shown here, like genetic factors, diet factors, we suggest the population shown here to receive early screening, such as age over 40 years old, people who eat a lot of red meat, people who smoke, people who drink a lot, they should receive early screening from the doctor. Okay? In terms of screening methods, which is one of today's most important topics, according to my knowledge, unfortunately, the current screening procedure is very simple and immature. Fecal occult blood is considered to be the first screening step as shown here. So if it is positive, then the doctor would suggest a colonoscopy. However, FOB has a relatively low specificity with colorectal cancer, which means, even FOB is positive, maybe only 30 to 40%, as shown here. Only 30 to 40% of them are caused by colorectal cancer. This is to say, more than half of the patients could receive colonoscopy without necessary. They don't actually need colonoscopy. So don't mention that most people actually are not willing to receive colonoscopy. Why? Some doctors told me before that even they recommend and prescribe colonoscopy, patients did not want to follow and they disappear and will not come back to see you again. The reason people are reluctant to this, colonoscopy is an invasive surgery actually, with some possible incidents like bleeding, like perforation, like death. So patient will feel very bad for the bowel preparations. And that is why, to save medical resource, making sure that only those patients who really are at high risk of colorectal cancer to receive the colonoscopy, we need to add a non-invasive, highly sensitive screening method to increase patient participation. To achieve this, we introduce the diagnostic kit for CRC gene methylation. So it is a diagnostic kit for CRC gene. To get you to understand more about this product, let me just go through the detection procedures for you briefly. As you can see from the flow chart here, at the beginning, I already mentioned our signature feces specimen processing methods. With the applied solution from the feces specimen, so we are able to extract the DNA. We are able to extract the DNA from the applied solution. Then we perform a conversion step before the qPCR to detect the genes for colorectal cancer. So actually, this is a qPCR detection kit. The clinical study from our research team found that certain modification is happening on those genes that are related to colorectal cancer. And here I would like to introduce a kind of a DNA modification form. It is called DNA methylation, which is founded in the cancer suppressor gene. This is the cancer suppressor gene in colorectal cancer patients. We could say that methylation is actually coming with cancer. So if we have methylation, then cancer is coming with it, because it disabled the cancer suppressor gene. It disabled the suppressor gene, which means the oncogene will be expressed to open the door for the cancer. Okay? It opens the door for the cancer. It does not directly cause cancer, but it opens the door for the cancer. Right? You might also be curious about why we are selecting feces samples for colorectal cancer screening instead of blood, because we all know that blood is the most easy samples that's coming from human body. Why? Right. Generally speaking, blood is not organ related because it goes across the whole body. It goes across the whole body. Even if we identify the methylation of gene from blood sample, we could not confirm which part of the body it is coming from. This is the problem. Yes, we know it is methylated, but where it is from, we don't know. We don't know that because blood is flowing around the whole body. We don't know where it is from. Moreover, colorectal cancer has less chance to enter the blood. Colorectal cancer has less chance to enter the blood, and it is often in the middle to late stage event. So it does not enter the blood in early stage. Right. So for screening, it is not as suitable as feces sample because it is a local and direct specimen from colon. Our products are similar to common PCR reagents that could be performed on many PCR platforms. And we utilize two genes as a combination detection to increase the sensitivity of the kit, which are called T1 and T2. So we use two genes together in the same kit to increase the sensitivity of the kit. With the natural features of feces specimens, our product could achieve early detection other than blood samples, and also it is safe to use and cost effective, so patient compliance is much better than colonoscopy. And as the methodology of our product is qPCR with multiple gene detection, the sensitivity and specificity are much higher than FOB and even comparable with colonoscopy. The detection result is accurate and credible. Lastly, sampling of feces is quite convenient, and the specimen processing could be done automatically. So we could say that it's an easier method than colonoscopy to screen colorectal cancer. Okay, this is the second part. This is the end of the second part. So colorectal cancer is a very severe digestive cancer. In the third part, I want to guide you through another digestive disease that's even more universal, covering at least 50% of the population in the world, which is Helicobacter pylori. From this figure, we could see that basically the prevalence of HP is very high across the world, especially in Asia, Europe, and South America are even higher, with 50% to 70% of prevalence. So it is a universal disease, kind of a bacteria and universal disease. We know that HP is the main cause of many gastrointestinal disease like chronic gastritis and peptic ulcer. And it is also the top risk factor for stomach cancer, with more than 85% of correlation. Generally, HP produces two main toxins called VACA and CAGA. They usually come together, and CAGA is the key factor for inflammation and gastric cancer. So CAGA is more harmful, but they come together. I believe most of you understand that HP, but maybe you seldom heard of classification of HP, right? So there are actually two types of HP, and both of them are urea positive. You can see that type 1 is urea positive, and type 2 is also urea positive. But what's the difference? Type 1 on the top, type 1 is CAGA and VACA positive. Means that this type of HP is producing these two toxins, doing great harm to stomach and increasing the risk of stomach cancer. But type 2 is CAGA and VACA negative, means that this type does not express these toxins. So gastric symptoms are normally slight. The symptoms are normally slight or even no symptoms. In China, the guideline of HP eradication demonstrates that the eradication therapy might not be necessary on type 2 HP because it does not make a big impact to human body. It's not doing harm to us, so it doesn't need it to be cured. That is to say, after identifying the type of HP, we could save some antibiotics on those patients who do not need them at all. The reason for saving antibiotic, I think you understand this concept really well, is to reduce resistance, which is a big issue for years in the world. As you know, the resistance rate is very high for many common classes of antibiotics, like amoxicillin on the left, like metronidazole on the second, like clarithromycin third, and tetracycline on the fourth part. As shown on this chart, actually metronidazole and clarithromycin are both the first line antibiotic for the eradication therapy. And you can see that the resistance rate has been increasing from 1998 to today. It's increasing. This one is increasing, and this one is also increasing because they are the first line of the eradication therapy. This means these drugs could not be used to treat other severe infections if we really need them. They will be useless. They will be not effective at all. So to relieve this severe situation, I would like to introduce another product with you, which is the Genotyping and Drug Resistance Gene Detection Kit of H. pylori. This test kit is for precision Medicare of HP. Same as our test kits for colorectal cancer, we also utilize feces samples with qPCR method to detect the CAGA gene. So we are detecting CAGA gene to determine the type of HP. Then, if eradication therapy is required, we perform another antibiotic drug resistance gene detection by qPCR also to guide the doctor which antibiotic they should prescribe. Lastly, we are coming back to this topic again, feces versus blood. We are comparing our products with another product on the market which is using blood. Precisely, we are using serum. They're using serum to identify the antibody. They identify the antibody of HP in serum. However, as we know that antibody takes time to be built, which results in an empty window causing false negative, because it takes time for the antibody to be built after infection. So we have false negative. And also, antibody could last long after infection. So antibody will not disappear after infection, which means even if we detect antibody from serum, this does not mean that we have infection now, causing false positive result. We don't have infection, but we could have antibody, correct? This is the reason why we have false positive results with antibody tests. On feces specimen, on the contrary, on the left, we are utilizing PCR method with much better sensitivity as we are dealing with HP itself directly. So we are dealing with the antigen instead of antibody, right? Okay, so this is the end of today's training section. Today, we went through our signature feces specimen processing technology. And also we go through 3 PCR test kits for colorectal cancer, HP typing, and drug resistance detection. So hope you have a great understanding of our new concepts and products. After this meeting, our sales representatives will give you a follow-up, sending you more details about this product and solve your questions in detail. So again, thank you very much for your time, and I will see you next time. Thank you.